Okay, let's go ahead and get started. First of all, my name is Dean Burns, and I am the president and CEO of Ocumetics, and I am just thrilled to have as many people as we have on the webinar join us this afternoon. By way of a disclosure, I have to show this. So nothing contained in this presentation is or shall rely upon or be looked upon as a promise of any sort. These are my views, my thinking, and it's an update as to where we are and certainly where we are going. So um, I don't want to mislead anybody about the organization. So by way of a presentation agenda, we'll do a quick little introduction. I'll talk a little bit about the problem that exists and what Ocumetics is trying to mitigate against. We'll showcase our solution and what that journey looks like as we make our way towards first in human. And then I will end the presentation with a little of the business, specifically the financial need to complete the technology. And then with my colleague, Dayton Marks, we will take as many questions as you want to pepper us with for the webinar. I always start with my experience because I think it's really important for you guys to get to know me, not from the perspective that I am at the helm of Ocumetics, but what has he done? What are some of the things that give him the ability to do what he's doing? So first of all, I've got a very solid medical and surgical experience that spans over 40 years. I retired after almost 28 years with Alcon Vision, which is the largest eye care company in the world. And I ran one of their largest divisions, which was responsible for $750 million of top line business and a very healthy growth rate year over year. In terms of personal accomplishments, I've got 15 FDA approvals. And I'm pausing for effect because many people in my position maybe get one or two. I've had the privilege of doing it 15 times, and this will be my 16th once we get this one across the FDA threshold. All 15 of those FDA approvals led to product launches across four eye care categories, which includes pharmaceuticals, and I've got 17 national awards. So some are sales and some are marketing. So I'm a hard driving kind of individual that likes to get things done. So what is the problem? What are we really trying to solve? Well, we're trying to solve the issue that plagues us all, and nobody gets a pass on this. We all have to go through this pathway, and that is as we get older, our eyes begin to deteriorate. And it goes through two conditions. One is presbyopia, which is the loss of accommodation, and it usually starts at around age 45. Once it progresses, you progress into what we call cataract diseases. And what that is that's where the crystalline lens, which you all have, gets cloudy, inflexible, and if not treated, which happens in some third world countries, not the US, it does result in the diminished ability to see or blindness. And that usually happens somewhere in the age of 65 or older. So we have this prevalence to go through this pathway, and that's what we're trying to solve. Well, Ocumetics, with the design criteria that came from Dr. Webb, has come up with an unbelievable solution to actually fix that natural progression and give you the eyesight back that you naturally had years ago. What is it? Well, here's a pictorial image of our lens. And there are a couple things that I'm just going to point out. So there's an anterior optic here, if you can see my cursor. There's a posterior optic right below that, and that is attached to these little crazy U-shaped or V-shaped appendages that are haptic. So that's what holds the lens inside the eye and does not allow that lens to shift. In between there, the white space, it is filled with air and or fluid. And as we go further into the presentation, you'll see why that's really, really important. All right. So in the normal crystalline lens, which is what we have in our eyes before we have surgery, the muscles, which on my pointer, flex and relax. When it flexes and relaxes, it pulls a lens that's already there and makes it thinner, and then it relaxes and allows it to become fat. That's what gives us the ability to see distance, intermediate, and near. Well, Dr. Webb came up with an ingenious way of mimicking the natural eye movement with our two lenses. So I gave you the pictorial version where we have an anterior optic here and a posterior optic here. When we activate these muscles, when the two lenses are brought together, that allows the patient to see in the distance. And this is what a patient would see. They can see into basically infinity as they're driving down the road. Well, when the eye relaxes, it goes into an accommodative state, which allows us to see either intermediate or very close up. And I use a word or a term called automagically, not because there's magic behind this, but there's a lot of science behind it. But the magic is the eye and the brain are in sync with each other, and the eyes are in sync with each other. And you don't have to even think about it. You just need to look and enjoy. And so that's what our technology allows us to do. When I look at the value proposition for the technology, and here are the things that you can actually put in your hip pocket and take it away. It's a one-piece air or fluid filled, what we call a shape-changing IOL. There are IOLs out there that don't change shapes, and so they don't fall into this category. In fact, there's other technologies that are being touted as being a shape-changing IOLs, but they don't meet the definition. It's designed to give us up to 3.25 diopters of accommodation. And so I equate that to, at some point in time, when you reach a certain age, you'll go to a big box store or the drugstore or maybe even your doctor's office and say, hey, I need reading glasses. And the doctor will measure you, or you can measure yourself, and you could get a quarter, a half, 3/4 of a diopter worth of reading support. You can get 1, 2, or 3. That's exactly what this lens does, except it does it inside the eye versus having a pair of spectacles on your eyes. And we can get up to 3.25 diopters worth of accommodation. Now, this is not the distance refraction. This is in addition to what that distance refraction would be like. The accommodative lens has both an accommodative component and a disaccommodative component. And our design goals have been to make sure that this lens disaccommodates within one section, within one second. The reason that's important is you don't want to be driving down the road with a distance activity and then look down at your phone or your console, which puts you in an accommodative state, and then look up again and have that lens taking its time to change back to the distance accommodative mode. We want that to be very quick and do it in such a way where you don't even notice it. And so 1 second is the timing that we put on that. We have a lens that is fluid filled or air filled, and we'll talk a little bit about what that really means, but it does not contain silicone oil. And the reason it doesn't is silicone oil has already been known to be toxic to the body. You don't have to even hear me. You can go look it up and see what they've done in the cosmetic industry, specifically for breast implants. When the silicone ruptures and it leaks into the body, it's very painful to those that have those types of implants, and it has to be removed from the body. So we've elected to just stay away from silicone oil. And that's important because our competition is still using silicone oil with this. So when we do a snapshot and look back at what Ocumetics has done for the year 2024, first of all, we've increased what we call our share of voice. What that means is that's us talking to the market about what we're doing, and we've done that in social media, PR, the CEO messaging, and the webinar that you guys are currently on. We have to be very careful about our share of voice because this is an unapproved product across the board, across different regulatory jurisdictions, and we cannot promote the product until it is approved. But what we can do is we can promote Ocumetics and what we're doing with the product and our development efforts and what our journey is, and that's what we have been working on. We've increased our network of interested partners. So we are talking to a lot of individuals, investment banks. We haven't done VCs yet, but high net worth individuals who are very interested in coming on board and looking at funding options and opportunity with the lens. We are also talking with some of the very large companies that are in the ophthalmic area because they are very interested in what this lens has the capability of doing. So that's pretty exciting as well. Additionally, we have what we refer to as optimized our design. So we had a lens version 10.6 ready to go so that we could actually take that lens into first in human studies. We took a pause, and I'll talk a little bit about the pause, to optimize the lens to make it better, and better in two ways. One, so the patient experience is that much enhanced. The second is to mitigate any kind of problem that you might have if you put a lens in and it fails. And so we were absolutely able to identify it early and then put the corrective action in place and fix it and get it done. The other thing is lens clarity. And so I would ask you to think through, if you had eyeglasses and your eyeglasses had fingerprints and smudges and stuff, your vision clarity or visual clarity would not be there. Well, we have a device that we purchased called the IOL lens analyzer. And what that device actually does is it tells us how clear the lens is following manufacturing. So we inspect 100% every lens that is made, and we take them through that process. And I'll show you what that device looks like here in a few minutes. And then, as I mentioned to you, we took a pause going into first in human with the lens design. So we went from 10.6 to 12.3 in our lens design. And because we took that pause, that was a voluntary pause, it actually put us back a little bit on our first surgery for first in human. And that's about 6 to 8 weeks from the published date that we had for that. That's not a bad deal because we voluntarily did that, and we did it for all the right reasons. And I'll show that here in a couple slides. All right, so let's take a nosedive right into the road to first in human. When I talk with investors or individuals who are interested in our technology, they don't realize everything that we have to do to actually take this from the bench and put it into a live patient. And there's a ton of activities that have to occur, and many of the activities are either ISO mandated or FDA mandated. And these are two standards that we cannot get around. So we take it very seriously and we make sure that we do a really good job, because the worst thing that could happen is we do all this work only to miss a step or go around something and have the agency come back and say, nope, we're not going to approve this and you need to do it all over again. So we are very careful about what it is that we do. The activities that we are involved in include first in human surgery. So what are all the things we need to do to manage the patient? Regulatory application. So what is the paperwork and the paperwork trail that we need to have in place before we actually do our first patient? And then finalization of R&D designs and making sure that we have all the documentation in the file. So if we do have a hiccup, we can actually go back and triage the file. When you look at first in human, we're using it's called a stop sign configuration to determine where we are. So green means that we're on track. So everything that we need to do is on track. The timing is good. We are checking the boxes with the Gantt charts, etc. Yellow means that we have a slight delay. Doesn't mean we have a problem. It just means that we are slightly delayed. And red means that we haven't started the activity yet. So if you look at the end of the year activity, so this is Q3 to 4, 2024, the activity, so we are right there at design lock. We have our version 12.3 that we are ready to take into first in human, so that's a good check mark. We have not submitted our regulatory application to the Dominican Republic and the authorities there, because we needed to finalize the protocol. And what the protocol is how are we actually going to manage the patients that will be in the study? And this is everything from pre-op testing, intraoperative surgery, and then post-op handling. And so that protocol is really important, because that's what we tell the authorities, the regulatory authorities or the Minister of Health within the DR, about how we're going to manage those patients. So we are slightly delayed because we needed to finish the protocol, and I just got it today. So I get to take a look at it here over the next day or so. So we're making good progress. We're just slightly behind. We have completed our injector system. So you might be wondering, how do you get these little bitty lenses into the eye? Well, you have to use an injector to do so. And I've got a picture, and I'll show 5 seconds of the video on how we load those things. So since we haven't submitted our application, we don't have regulatory approval. We can't do yet our clinical pre-site visit, and we can't do the clinical inspection, and that is just making sure that we go into a sterile room and it's bacteria-free. So those are the only 2 things, but once we submit the application, those 3 things actually go pretty quickly. When you look at Q1 of 2025 activity, same type of configuration, green, yellow, and red, but the activity level is a little bit different. So the first thing we have to do is send all the supplies. We have to finish the surgical procedures and surgeon training. The good thing is we only have 1 surgeon that we're training, so that shouldn't take a lot of time. We got to recruit the patients, conduct the surgery, manage the patient, and then do all the clinical reports over a 6-month period of time. Beginning that process the first quarter of 2025. First surgery, by the way, for first in human will be will be second quarter of 2025. So that's first surgery, but there's a ton of activities that have to take place right now in order to be able to manage the surgical event with these patients. Okay, so I mentioned to you that 100% of our lenses are inspected. We purchased a lens analyzer from Israel called the IOL machine. And what that machine does is it looks at every single lens, both anterior and posterior lens that we manufacture, and it tells us the quality of the lens. It gives us numbers that we need in order to pass the lens and say it's ready to be put into a patient's eye. Now, this image doesn't mean anything to you guys, but that image tells me how high quality the lens is, and is it aberration free, or do we have a tilt or wavy line that actually can create a problem with putting this lens in a patient's eye. So we spent a lot of money actually to purchase this. It was one of the best investments that Ocumetics made because it took the guesswork out of everything that we're doing. And that's one of the things we use for manufacturing. The other thing that we did was we identified a Chinese company to actually make the individual molds for our lenses. And so these are it's a example of the molds that we have. So they put the silicone into the mold, they bring these two pieces together, put it under pressure, then they cure it, and we have what we refer to as an optically quality lens. Now, this was the very first versions of this. We have now advanced ourselves to have multiple molds that have 6 to 8 places where you put the silicone in, compress it under the compressor, and allow it to cure either with heat or room temperature. And so we can make many more lenses at a time. But this is how we started. We were making one lens at a time. I had mentioned to you that we have an injector. And so this is what the injector looks like. And I'm just going to run the video. So that's an Ocumetics lens that we manufactured. We put it in what we refer to as the loading chamber. And we close the loading chamber and we force that lens into a taco configuration. So once it's locked in place, we advance it into the window so that we can see now it's a taco. And as it comes out the distal end of the injector, as you can see right there, that distal end is actually put into a incision in the eye, and it's rotated in the back of the injector. That lens is rotated into the eye. So that's how we do surgery and get the lens in the eye. So we took a momentary pause to do an upgrade on our lens and optimize it. So we're no longer at 10.6, we're at 12.3, and that's just our R&D nomenclature so that we can keep track of all these lenses. We have a fiduciary responsibility. It's called track and trace, to be able to trace from birth to death of any technology we come up with, just in case there's a recall, patient adverse issue, or we have a problem with the lens in general. So we keep track of all that with all these different version controls. So we're at version 12.6. The reason we're there is as we were putting the lens together to do the first in human, we noticed that we had a challenge with compressing the lens. And so I'm going to put my pointer up here. So this is 10.6. We have a muscle that's up here, and we also have a bag that this lens sits in, that when that muscle is activated, it actually pushes the top part of this configuration down. And these two pieces have to touch each other. And I'm doing layman's language here. Well, we realized that we couldn't compress the black annulus, if you will, the way it needed to be compressed. So we needed we needed to be under 80 millinewtons because that's what's in the eye to do that compression. We originally were at 750 millinewtons to do the compression. It was very high. And so what we did to get to version 11 was we stripped out material. So we said, okay, well, let's just thin the material out, and that should alleviate the problem. Well, it didn't, because we got it down to 350 millinewtons of force. And then we said, let's change the material. So this lens is made up of two different materials. One is black and one is clear. We made the lens with just the clear material, and guess what? We hit 40 millinewtons. We solved the problem. The material that we had was not compressible at the level that we needed. So here's an animation to show you how the lens is supposed to work in the eye. We're supposed to be able to push it up and down using the eye muscles to do so. So you see that opening? Now it's compressed and closed. It's open, it's compressed. So that's how the Ocumetics lens works. And this is a computer animation to showcase that. Here's the device that we actually use to compress the lens. And I'm going to just run just a little bit of this. This is in real time. And this is what we found out, that we couldn't compress the lens at the right level. So here's the compression in millinewtons, and we're compressing the lens down. Here's the weight. We're compressing the lens down. Here's the gap or the opening, air or fluid. And now we're starting to compress that. We're at 2 millinewtons, which is really good. The lower the number, the better we are. It's up to 4. And once we get up to about 10, you'll really start to see lens touching. In fact, you can see it now. So the lens is touching right here where my little pointer is. And then you'll start to see this whole area close in. It's touching right here on the screen. And we're at 13 millinewtons. So this is done down in Monterrey, Mexico, in our design laboratory, a company called Bioana. So you hear them talking in their natural language. And they are reporting where we are, and this thing is already closed. It's completely closed, and we are at 22 millinewtons. So we know we figured out what we needed to do. So I'm going to take a change of pace and go in a different direction, because we can come back to any of the clinical stuff or design stuff during Q&A. We have a business model that basically suggests that if we do what we need to do in terms of designing this lens and then commercializing it with the right targets, we have a $500 million business on our hands. Now, to give you perspective on blockbuster, and this is just one product, to give you a perspective on blockbuster products, if you have a product that's between $50 and $100 million, it's considered a blockbuster. Pharmaceuticals are a little bit different, but if you have a product that's kind of in that range, it's a blockbuster. Well, we far exceed that, and we're using 2022 data to build our models in the cataract-only area, looking at specific things that have not changed. The biggest thing for us is we want to go after a 40% share of the market. I'll give 60% up to the other 5 or 6 companies that are fighting over this business, and they could each have, 10, 15, 20%, or even 3. I want Ocumetics to have 4, and we're putting in place parameters and procedures to make sure that we're able to garner that 40%. And that's only in the cataract-only age group. If we get approval to go after the refractive and cataract groups, and we keep everything together, it's about a $700 million revenue product. It's very significant. And we have the ability to do so because we have a very, very good product. So our fundraising history and projections have been really good. Right now, we're working on pre-manufacturing and our first in human study, so good check mark there. Once we get in and out of, or in and through first in human, we are probably going to have to do a Series A extended bridge funding, because we found out that there's some equipment that we're going to have to source in order to do the multi-center clinical trial. And so the sourcing of that equipment, we're working with the manufacturer right now. They don't want to look at financial options for us that we believe make sense. They want us to just buy this equipment just right out. And the equipment is very expensive. So there's about $1 million that's going to be needed for the clinical accommodation equipment, and then another $250,000 for the multi-center study to collect all the data and to automate that whole process. So that's where that bridge funding comes from. And then certainly we'll be in Series B with the multi-center clinical trial. And then from that, we'll start to look at the regulatory approval and early commercialization activities, and we'll need money for that as well. Now, when you look at competition, I equate it to like a racehorse. Everyone's out of the gate. So there's 14 companies that are in this category, which is good because it legitimizes the category. There are only 6 of us that are like right there up against the rail, not really fighting it out, but we're trying to do our own thing. 5 of the 6 companies all use silicone oil technologies. Now, I just told you earlier that silicone is not good for the eye. In fact, I did retina surgery for a long time, and we would actually use retina silicone oil as a eye tamponade, but then we would actually take it out because it's very toxic to the eye, and we would take it out. Well, they have put their lenses in a configuration where they need silicone oil to actually make the lenses move. And the lens material that they're using, which is more of an acrylic material, is very tacky. It likes to stick to itself. Well, to keep it from sticking to itself, silicone oil is a good media to prevent that. The problem is you have all of the issues associated with silicone oil in the eye as we understand it a little bit more. It's the same issues that we had when the plastics industry used it for breast augmentation. We are the only technology that is non-oil. And I mentioned earlier that it's air or fluid. The fluid is what naturally occurs in the eye. It's called aqueous fluid. And so everybody has aqueous fluid in their eye. And that's what our technology uses to do what I just showed you, the squeezing of the technology, and then the repositioning back to where it was before you were in an accommodative state. So the disaccommodative state is what the fluid helps to do. So we're the only non-silicone oil technology, and I actually consider myself an expert in opposition messaging. So I'll take the best of what the competition has and I'll turn it around and use it against them. And so we are getting information as we speak about where everyone is, but the 6 companies that you guys should really watch is the 5 that are on here and the Ocumetics that's at the top. And we're going to dominate. And I hate saying that word, but that's how I really feel. We're going to dominate this area. In fact, as I think about where we are and where our stock is, we are so undervalued right now. So I would encourage you guys to go and take a look at, our stock play, because once we get in to first in human, uh, we're going to see a lot of changes with the stock portfolio, et cetera. When you look at IP, we're in a very strong IP position. Anywhere in blue represents where our IP is. So we have 3 provisional patents. If anybody on the call understands patents, the provisional patent is the one that basically it's a process patent. So it's very difficult to get around a provisional patent because everything in the kitchen sink was put into those patents. So it talks about customization and lens geometry and all the optical elements and how this thing really works and interacts with the biotissues. That's all in the provisional patents, and we have 3 of those. We have 46 extended patents around the world, and these are patent registrations with the World Patent Office in all those areas that you see on this screen that are in blue. We are well positioned from a patent perspective. You see red circles on this particular slide because as we go in and out of our multi-center clinical trial, not the first in human, but the multi-center clinical trial, as we go in and out of that pathway, we're going to look at opportunities to do early commercialization or potential early commercialization. And that's where the red comes in. The countries that are in those circles have very friendly regulatory pathways. And so once we get into the multi-center clinical trial and we get that first tranche of patients done, we'll follow those patients 1 month, 3 month, and 6 month. And we'll start looking at the data, and we'll use that data to have conversations with the different regulatory bodies and ministers of health in the areas that I have in the circle. And we're pretty excited about that. Okay, so I have gotten through a presentation fairly quickly, but I did that so that we could have more time to just have a fireside chat. So with that, Dayton, I've talked for almost 45 minutes. I'm going to stop talking, get something to drink, and I'm going to start taking whatever questions you may have.
Excellent. Yeah, we've got a few questions already, in the pipeline. But if there's any other questions, you can type those in, and I will disseminate them for Dean to answer. You got your water there, Dean? You're
I do. I do. I just took a big gulp. I'm good to
excellent.
go.
Got mine over here as well, so gotta stay hydrated. All right. The first question that we had was with respect. It's actually a question that's come from a lot of people. With respect to participation in the trials, maybe you could add some comment on that. With
Yes.
respect to the first in human, obviously, and then perhaps the latter, full human trials.
Yep. So let's just talk. Let's take first in human first. If you live in the DR, Dominican Republic, and you want to participate in the study because you live there, you will have to reach out once we make the announcement, and we will through a press release to the clinic that's there and just tell them, hey, I'm interested in being a part of the first in human trials. If you don't live there, you cannot be a part of the first in human. It's just not feasible for you to do so. Now, the multi-center clinical trial, and so that's one clinic. With the multi-center clinical trial, we're going to have 13 clinics around the world. The majority of those clinics will be in Europe and the US and a couple places in South America. The reason I'm looking in the distance is I'm trying to pictorially look at the map that we had put together for the clinics that we wanted to work with for the multi-center clinical trial. So once we make that announcement, if you live in those geographic areas, you absolutely could be a part of the trial. There's no reason that you can't, but you will have to go through all the things that everyone has to be a part of a trial. So you've got to be healthy. You will have to come in and do, the eye health. I call it an eye physical, so that the surgeons understand your eyes. You'll have to sign up to come in on regular intervals to be tested because once we start that trial, the FDA requires us not to lose any patients due to follow-up. So we want to make sure that you can make your doctor's visits, et cetera, and you're willing to do that. So yes, we encourage you to want to be a part of it. It's just a matter of logistically making sure that there is a clinic uh, fairly close to where you're going to be. You're going to be.
Excellent. There's another question here. It's actually with respect to myopia. Do the lenses represent or offer treatment for myopia as well?
Yeah, so let me dispel this whole notion because I get that question all the time in emails. When we do cataract surgery, we are correcting one of two things. We're correcting myopia, hyperopia, or astigmatism. We do that in general. With an accommodative IOL, we're adding to myopia, hyperopia, or astigmatism and giving you the ability to see at multiple distances. So we call the myopia, hyperopia, or astigmatism the refraction or the refractive component of the lens. And then we layer on top of that the accommodative amplitude. So uh, can you see up close? Can you see mid-range? And then can you certainly see at a distance? And is this lens doing it? Here again, I'm going to do my automagically term. So yes, we do correct for myopia, and we give you the ability to have some kind of accommodative opportunity with the lens.
Excellent. Another question here from Jeremy. You distinguish between the approval for cataract and approval for refractive surgery. What factors might influence whether or not you get approval for one but not for the other?
Age. So typically your refractive patients are younger, and typically they have the ability to be corrected with glasses, contact lenses, or laser surgery. So younger and their modalities of corrections are totally different than with a cataract. When you are a cataract age patient, you actually have a tissue that has gone through its evolution and it's pretty diseased. It's not flexible and light cannot penetrate through it. And so when you're at that level, we have to remove that tissue and put the prosthetic in. So sometimes we refer to these lenses as a prosthetic lens. Those are two entirely different regulatory indications. So with a refractive patient, it's called a clear lensectomy. So it's not cloudy, it's not inflexible, it's an elective thing. And to do that, you have to get a different approval through the FDA. And most of the countries index off of FDA, so they're going to ask for the same thing. And we would have to do, it's called a companion study on younger patients. So the biggest influence is age. And then the second influence is certainly the health of your eye, not the cornea, not just the retina, it's the center part of the eye.
Sorry, excellent. This is a this is a great question, and I'm remembering back to actually Dean when you answered this one for me, and I got quite a chuckle out of it. So this one is curious to know when you did the animal studies, have you been able to test for accommodation? If so, how? And not just the ability of implantation. And I remember how you answered this one, and this was, anyways, yeah. So I'll let you answer this.
Yeah, so when we do animal studies, we actually do them in purpose-bred bunnies. So these are not your bunnies that you get at the pet store. These are New Zealand bunnies that are purposely developed and raised to do eye surgery and eye studies with. The problem with uh, accommodation with an animal is they can't read and they can't look at a target and you can't measure it because we have no idea what they're doing. So to actually see if we could do accommodation on an animal, we don't actually do animal studies for, in this particular case, for accommodation. We do animal studies for safety. So we want to make sure that if you put this lens in the eye, the material does not affect the eye. The eye doesn't get inflamed. The eye doesn't kick off a cascade effect of inflammation where you've got healing membranes everywhere that were caused because the body is trying to reject the implant. So we do it for safety reasons. And the interesting thing about it is you can't do first in human and you can't do a multi-center clinical trial until you pass safety. So that's the gateway to get into the FDA protocol and the FDA pathway. And so to be on that journey, we had to pass the biocompatibility and show safety with the lens compared to the gold standard. And then from that, we can start looking at doing all of the performance things that we need to do with humans. So humans can look at an eye chart. They can look at a chart in distance. They can look into a device and we can do contrast sensitivity, which is the different levels of gray that they can see. So it's 256 shades of gray that the human body can see. So there's so much more that we can do with the human because we can tell the human what to do and where to look and how to look, but you can't do that with an animal. I wish we could because we would have these studies wrapped up very quickly because we could do a lot of that work in the animal, but we just can't. We start with safety in animals, and then we do all the performance on the lens capability in humans.
Perfect. Thank you very much. All right. The next question is from John. I'm curious about the cost of the lens, or how much the lenses would cost. If no costs are being discussed, then no worries. So just a comment on the cost, which I think is
Okay,
obviously,
so
yeah.
yeah, so I get this question a lot too. Um, we are not allowed to actually discuss cost. I think what John is asking for is not cost, it's price. And so, what I would ask John, I don't know where John is located, but what I would ask John to do is to find out in his local area what the price of a premium surgery is. Because I really think that's the question he wants to know. And I can tell you that we will be price parity with a lot of the technology that already exists out there. But we're not at a place where we can actually talk about cost or price because we're still in a development type mode. So the pricing can change. And because of the regulatory considerations, we can't even talk about it to begin with.
Tony asked a question. As investors, will we get a special option to get surgery early, or is there special consideration for investors?
It's actually illegal. Uh, um, wow. I got to be very careful because I know this is being recorded. Um, so Tony, here's the deal. You have to work out whatever pricing considerations you have available to you through either private pay or insurance. And that has to be worked out directly with the office that's going to do the surgery. The manufacturer can't get in between there. It's not like a consumer product like electronics, where we could say, hey, we're going to pass on a value discount for anybody who buys a TV. Well, we can't say we're going to pass on a value discount for anybody who gets eye surgery because we don't actually set that price. The insurance company said it, the doctors in the local area said it, and the hospitals or freestanding centers set that. The manufacturer doesn't set that, and we can't tell them how to run their business. So we don't really have a mechanism to give you a coupon so that you can get 50% off of your eye surgery. Now, there are some places that actually do give you a discount, but you'll have to find that out and talk to those local places uh, once the lens is available and you're ready to have surgery. I'm sorry.
All right, perfect. Thanks so much. The next one's from John. It's how can you ramp up production and still maintain quality control and testing? And then there was also a question that pertains to pricing, which I think we've already answered.
Yeah. So let's do QA and manufacturing.
Yeah.
Um, so when you do manufacturing of technology like this, you can do it in one place or you can do it in multiple places. The lenses that we are making right now for first in human and the first part of the multi-center clinical trial are made in Monterrey, Mexico at our design studio. So it's called Bioana. You can look them up. They design, develop, and manufacture small batch technology. And when I say small batch, I'm talking less than 50 pieces. Our true manufacturing, which is our multi-center clinical trial and early commercialization manufacturer, is an organization called AmiPlant, and they are in Erlangen, Germany. They have the ability with these really big, they call them CNC machines, where they can just spit out lenses like you wouldn't believe because it's automated. So we do all of our early testing and development work in Monterrey, Mexico, so that we can maintain our QA and 100% inspection in Monterrey, Mexico, and they do small batches, less than 50 or less lenses. When we get to commercialization, we get to automate this whole process. And when you automate it against Six Sigma manufacturing standards, and you pool batches and you sample through batches and you keep that quality control going. And we do it in Erlangen, Germany. So we actually have two manufacturing facilities. We did that on purpose because we needed to make sure that we had expertise in two places. The other thing is we needed some redundancies. So if we can't do something in Mexico, we can actually, because we've duplicated it, we can actually do it in Erlangen, Germany. The only difference between the two facilities is the logistics to get the lenses to a certain location. And those are things that we're working through as we speak.
Perfect. Okay, we got another question here. I'll take this one, Dean. It's is there any more funds needed for private placements? Yeah, like I said, I'll just answer that one. At the particular moment right now, there is no open private placement. However, as stipulated in the slides, there are cash flows that are needed for the R&D process. So what you can do is you can keep an eye on the Ocumetics' website, in particular under the Investors tab, where you'll see press releases. If there is an open private placement that is announced, you can view that there. And or if the private placement is announced, often we'll reach out to investors as well.
Great answer. Thank you.
The next one's from Jacqueline. When talking of potential market share, are there values quoted referring to annual revenue, or is this the entire market potential? So I think that was with respect to revenue that on those slides that we were looking at previously.
Yeah, so that's a revenue slide for us. The value of the IOL market is almost $5 billion. Of the 5 billion, there's a category called premium, which kind of goes back to the other question I answered. That category has a whole bunch of lenses in the category, and it's almost $2 billion in that category alone. And so we want to dominate that particular category. Now, we won't do that day one. There's certainly going to be, we call it trial. So doctors will, once it's announced, they'll want to try it. Then they'll go through a usage, and then they'll go through adoption. I don't want to stay in trial. I want to get to usage as quickly as I can. And once we get into usage, we want to make sure that instead of trying it on a couple patients, they say, hey, my surgical schedule has 20 patients next week. I'm going to use this lens on all 20 patients as long as we have the range of lenses that they need for those patients. And so I want them using our lens on a regular basis, and eventually they will adopt it as their standard of care lens for their patients. So we're going to do things to make sure that we can get them out of trying or the trial stage and get them into usage, and then certainly adopting it as a standard of care. So good
I'm just
question.
gonna, sorry, yeah, I was just gonna give a yes and here and add to that as well, Dean, that with respect to the valuation aspect of it, the figures that we quote are revenue, which is the top line of the income statement, and the valuation side, which is the share price and associated market cap or enterprise values, are often multiples of that. In particular, it's usually the EBITDA multiple that we quote in finance. So in particular, if we're talking about a $500 million top line on an annual basis, the value of the corporation, tends to have EBITDA multiples that are, from any range of 5 on the low side, depending on the industry, up to as high as 20 and 30. I think it's closer to about 15 plus for our industry, if I recall correctly. So that doesn't reflect that's just the annual top line valuation. The actual fair value market cap and enterprise values can be far, far, far higher than that, in particular multiples of that. So the next
Good
question
point,
here.
Dave. Thank you.
Yeah, no problem. John has a question here as well. Have you done fatigue testing of the lens system?
Yes. That is a ISO standard, and it's something that every manufacturer has to do, and we have to report those values to FDA through the ISO process. So absolutely.
Another question here. I think we've already answered this. It's just how do you become a trial subject? I think we've answered that succinctly so far.
Yep.
So I'm gonna pass on that one. The next one is, Dean, can this replace all current intraocular lens technologies and businesses, or just for certain patient profiles?
And this is my personal opinion, okay? This should be standard of care. This lens should replace everything that's out there, and we should remove the barrier for that to happen. So in the premium category, the biggest barrier in that category is price. It's not cost, it's price. And it's the price to the patient. So most patients can't afford to pay for it. And then most insurance companies, or at least the managed care side of that, cannot afford to take that up and use it to replace everything that's out there, because the manufacturers actually priced it. So it's more of a niche. than anything else. So if you look at the US and Canadian system, uh, they're not going to pick that up as, the product that's going to be used on every patient. I want to change that paradigm, and I want to price it where everyone can afford it. And if they can't afford it, I want to give them a vehicle to at least be able to pay on it, because we believe it's going to give them the best vision. So if you're a 65-year-old and we can give you vision that you had when you were in your early 30s, why wouldn't you do it? And I think we have the ability to do so, but we just have to make sure that we don't put up any artificial barriers like price to prevent patients from being able to take advantage of it.
So Gary has a question. Will there be any clinical options available in Canada?
In terms of the multi-center clinical trial,
I think perhaps that, and then I guess availability with respect to the lens after FDA approval.
yeah.
Maybe
So
after both.
so I'll be a little transparent here. There are two sites in Canada. So when I kind of went through clinical sites, I kind of glossed over it because there are 13 sites. Two of the 13 are in Canada. And what we're trying to do is to make sure that we can cover both coasts. So if you live in the middle of the country, you can go either way. But we're trying to make sure that we can cover both coasts. So there will be two sites.
Perfect. So Tony asked, I remember when I did an RK way back in the 80s, I had to go for adjustments. Will this be the case for Ocumetics?
No, uh so when you have cataract surgery, it's a permanent surgery. And if we hit the refraction, which I think we will, which is the calculation that we have to do to determine what the lens is, uh, there are no adjustments. So you're one and done. The thing about RK is when you put incisions on the cornea, which is what RK is, radial incisions. One of the things that cannot be calculated in the nomogram that tells you either 4, 6, 8, or 16 incisions is what the healing is going to look like. So the cornea is like skin. It's going to scar, but it's a clear scarring. And we can't determine what the healing is going to be. So that's why you have to go back for adjustments.
Excellent. John asked, would these lenses need to be replaced over time, or would they just be, would there be just one set of lenses implanted and they're good for the rest of your life? I mean, kind of answered that in the previous one, but just to follow up on that.
Yep, it's the rest of your life. One and done.
From what you know, are lenses intended only for cataracts or other problems potentially addressable, such as nystagmus?
So that's a different problem. So when you have nystagmus, is that what you're trying to say?
I think that that's what it is. Yeah, yeah.
Yeah, yeah. So um, so that's a movement of the eye. That's not a refraction in terms of the quality of vision that comes from seeing distance, intermediate, and near. When your eye, it's like a tremble. When your eye moves like this, there are other things that they have to do. It's a different condition that they have to manage to give a patient better quality of life. So that's kind of one of those things you'd have to take up with your healthcare professional as it relates to your eye, because that's a different condition, totally different.
So we have a question here. Will the version of the lens used in the first in human trials provide up to 3 times better than 20/20 vision? Yeah,
All right, so uh, 3 times better is a implied guarantee that we cannot make. So if it's 3 times 20/20, that's 2016.5 or 2015, 2012. 20 over 8. So we're talking about vision better than an eagle. You can't make that claim because unlike the eagle, if you do surgery on the eye, you have to take into consideration neural adaptation of that new thing that was put into the optical pathway. So the brain and the eyes, because they have to be in sync, you have to neural adapt with that. You have to heal. You got to make sure that you don't have any other systemic diseases associated with your eyes that could affect your eyes, like diabetes and glaucoma and stuff like that. So to make an implication that it's going to be 3 times better is probably not a good thing. The other thing is, if you have 3 times better than 20/20, your brain probably wouldn't like that vision. You could actually see snow dust in the air, and you wouldn't like that. So if you can get past 20/20, so let's just say 20/16, that's better than 20/20, and your body will actually love that type of vision. Even 20/12.5, your body would like that. Is there a potential? There's always a potential to get better than 20/20. But your healthcare provider is going to have to take all those things into consideration. One other thing is surgeon skill. What is the skill of the surgeon that's putting that prosthetic IOL in the eye? Did they just graduate, or have they been out there, and do they keep up? And so you have so many variables that are really difficult to control. And I wouldn't want to put an implied guarantee out there that it's going to be 3 times better than 20/20. If you're 20/20 and you're reading at that 20/20 level, your vision's really good.
Just to add on to that, the I think the biggest factor with that question is the implied guarantee that the FDA may interpret. I think it's just very important to make it clear that if you make a guarantee, the FDA will hold you to that. So as a result of that, that's the biggest key with this, is that we don't make guarantees, because that can be in violation of our obligations with the FDA. Um, just to add on to that. There's another one here. You had said something about getting 3.25 diopters as possible. What is the maximum lens power?
Okay. So you have to separate the conversation. The maximum lens power goes from 19 diopters on the low end, which is more of a sizing thing, all the way up to, I think we can do 34. So that's the lens, how it fits in the eye, and the distance from the back of the eye to the front of the eye are all those calculations that make that up. So we can make a 19 to basically a 34 diopter lens. We add on top of that the accommodative component, and we can make up to 3.3 diopters of accommodative amplitude. This technology on the bench has been studied up to 14 diopters worth of accommodation. It is unethical to put 14 diopters worth of accommodative amplitude in the eye, because even as a child, you don't have that. So we would actually be putting something in the eye that the eye didn't have. Or if it did have, as you got older, it diminished. So 3.25 is exceptional. And so we have the ability to accommodate the full range of patient errors and give them 3.25 diopters worth of accommodative amplitude.
Perfect. The next one is, when this goes to market, will it be restricted to patients that have had, or sorry, that have never had eye surgery?
Nope.
And perfect.
Nope.
And then in particular, they mention cataract surgery, which, PRK, and then the accommodative crystalline lens, and then LASIK. as
Okay.
examples.
Yeah. So let me separate the conversation and the technologies. So when you have PRK or LASIK, what we're doing is we're reshaping the front part of the eye, the cornea. And it depends on what part of that vision we're trying to fix. So there's a different way to do it for myopia, a different way to do it for hyperopia. And when you have astigmatism or mixed astigmatism, there's another way to accommodate that. So that's all on the cornea. When we put a lens in the eye, we're looking at what is the eye's ability to see in the distance and what would the eye's ability be to see up close. So if you have any of those conditions that were corrected when you were younger, it makes the calculation a little challenging to do, but we have nomograms now that allow us to do those calculations and get the right lens power put in your eye so that you can see in the distance, intermediate, and up close very, very, very well, irrespective of the previous technologies or previous treatments that you had. But here again, this is a conversation that you absolutely have to have with your healthcare provider, because those are the guys that are or gals that are going to make the decision as to what lens you get put in your eye.
Perfect. So will trial patients be selected from various age groups to determine acceptance in those age groups?
That's one of the inclusion criteria that you use anytime you do a trial. And in particular, when you look at the multi-center clinical trials, FDA actually wants you to have a well-rounded group of patients that you have in your trials. So yes, we will do that uh, specifically when we do the multi-center clinical trials. That's part of the inclusion criteria.
Another question here is in case of high myopia patients and to anticipate presbyopia in the Ocumetics lens present status, a good option to improve the vision after 40 years retinal sorry. Uh, After the age 40 and the retinal detachment risks, um, maybe let's just synthesize that down into how does the lens work with high myopia patients and is there risk of retinal detachment?
Yeah, so it doesn't matter what lens technology you're using. If you are a high myope, the risk of a retinal detachment is actually really high. Doesn't have anything to do with the technology. It has everything to do with the anatomy. So if you're a high myope, long eye, the chances of a retinal detachment is pretty high. And you could be a 25-year-old or you could be a 40-year-old. It's because of the anatomy. So what your doctor may do is do more tests to help them understand the probability of a retinal detachment following cataract surgery or following a clear lens extraction.
Right.
And
There's
so,
sorry, go ahead.
no, go for it.
There's another question here. I'm not familiar with this disease. Again, I'm the finance guy here, but does the lens treat someone with Keratocon's disease?
Yeah, I got you. I got you.
Appreciate it.
No. Good pronunciation, by the way.
Did I get
So
it?
that's, yeah, so that's keratoconus.
Okay, perfect.
Okay. So keratoconus as a disease is the bulging out of the cornea itself. So I'm gonna use my knuckles here. The cornea will begin to bulge out at some point. It's usually inferior um, nasal, but the cornea will start bulging out, and as it bulges out, it actually gets thinner in that area. And the patient's vision is terrible. because you have to use contact lenses, hard rigid lenses, to actually reshape and mold the cornea. And if it gets to the point where that's no longer working, typically those patients will have to undergo either a corneal transplant, or they'll have to go undergo what's called corneal cross-linking, which is a new procedure for keratoconus. Either of those procedures, you have to get the keratoconus arrested before you do the cataract procedure, because the optical system begins and ends with light coming through the cornea. And that cornea has to be stabilized so that you can do the right calculation. So they'll work on the diseased cornea first, stabilize the vision, and then do the cataract procedure. And they won't do all that together. They've got to let the eye heal. So keratoconus is one of those. It may end up being an exclusion at first, because that's a disease process you have to get arrested. You also have to get glaucoma under control. You also have to get severe dry eye under control in order to actually have a successful cataract procedure.
You mentioned that the prosthesis would fix myopia. Is there a limit to which the correction can be made by the lenses? If so, what would the limit be? For example, -10, -5, etc.
Um, if if you are a -10, you may have to have multiple two procedures. So you may have to have a procedure to correct the internal lens, and also have a procedure to change the shape of the cornea so that we can get the light rays to focus on the back of the eye in the right place. So that would be a very long discussion with your healthcare provider, so that everybody involved in this understands the risk associated with doing those procedures together. So we don't make lenses into infinity. They do have a range. A -10 is a very high myope, and a +4 is a very high hyperope. And we do have lenses that can be put in the eye and calculated for patients that are dealing with that. But that's a really long discussion with your health care provider so that they can actually plan the surgery out the right way.
Excellent. Here's another one, Mr. Burns and Mr. Marks. OTC looks quite promising as a technology. However, I'm concerned about the company's ability to remain funded. What steps have you taken to conserve funds for research and development?
Well, so let me just talk about R&D in general. When you start looking at burn on cash, when you go from bench work, which we've been there, to managing patients, your burn rate goes up exponentially. And the reason it does that is the patients have to be compensated for being a part of the trial. And all of that stuff is actually worked out at the practice level. So the expense at the practice, the expense of the doctor, the expense of the technicians, and then the expense of the patients are things that the organization has not had to deal with, because we've just been making lenses to go into rabbits, or making lenses to go through ISO testing, which is more of the safety stuff that I talked about early on. So if we shut off the funnel for cash, the place that we would have to shut it off is the place that we're trying to go to. It's kind of like playing hockey without a puck. We're trying to get the technology into a patient. And so that's where the biggest expense is. Certainly you have administrative expenses and you have staffing expenses. So I'm not minimizing that stuff. But when you go from bench to clinical, your burn rate actually goes up. And that's just the nature of surgical devices.
Excellent. Sorry.
Then we got about 6 more minutes of questions, and then we'll cut.
Yeah, we're running out of time here. Okay, we've got quite a few like we've still got like 30 plus questions here.
All right, let's see how we can get through some of them.
Yeah, okay. Let's try and I'll try and pick out the best ones. Um, so the study plan is first to study older patients to get approval for cataracts, and then to study younger patients to get approval for refractive correction.
That's correct.
Okay, excellent. Got another one here. Did I understand that that obtaining regulatory approval for refractive surgery in younger patients might not be easy?
That's not what I said.
Okay.
Uh, to get regulatory approval in younger patients requires another study.
Excellent. Okay. As soon as you're successful with human studies, do you plan to market these in different venues like major news outlets, YouTube, TikTok, etc.?
Absolutely.
Okay. Um, Oh, yeah, this is a good one. Since small batches of the lenses are made in Mexico, I heard, or at least we heard in Mexico, will any tariffs affect the company's progress?
Hopefully not.
Great answer and great question. Um, yeah, that's an issue. We can buy stock on the open market as well, right? I'm planning on buying additional shares now in January in the U.S. markets. So I'll just jump in on that one. So just if you're buying on the U.S. markets, I just want to warn people to please be careful with your orders that you place. Ensure again, if you're buying on the U.S. markets, that you use what they call a limit order as opposed to a market order, especially if you're doing orders that are in excess of $20,000. And the reason for that, of course, is due to liquidity. There is less liquidity in the US markets as opposed to the Canadian markets if you're doing so through a discount broker. So again, I just want to make it very clear, please, please, please use a limit order. Do not use a market order. You don't want to have an instance where you're buying the shares at the nearest available seller, which could be $3 for all you know. So again, limit order. Randy asked, are there any other technology positive features besides the cataract and refractive features? Will it adapt to AI glasses, or could it?
Ooh. Um, so we have I'm trying to decide how I want to answer this so I don't get in trouble. We have a strategic R&D project list of next generation technologies, next generation opportunities, uh, and it's aligned with what's happening in the market. So this is really on the research side. And so when you start looking at adaptive optics and things of that nature, you have to understand, first of all, how that technology is going to be deployed. And will it be deployed in such a way that I can take advantage of their technology or they can take advantage of my technology? And so there's a lot of stuff that's out there. I get the question about AI all the time as it relates to manufacturing. And so I can't say with any high level of certainty that we will have AI helping manufacture the Ocumetics lens because I don't know how far the AI technology has gone to where it can replace a optical engineer. What I do know is that technology continues to get better and better. And at some point in time, we may want to consider it. It's in the car industry as an example. Um, Tesla just announced that they've got bots and AI making their cars. Well, that's a little different than making a little small lens that you put in the eye. But having said that, we have to be positioned to take advantage of any technology that's coming down the pathway that can help improve our products. And
So go ahead.
no, I was just going to say, and we try to capture that in our strategic R&D strategic plan.
Uh, So there's another one here. In November, the message from the CEO, it was mentioned to implement these changes, we will need to reorder the raw materials and create a new lens mold. Have these raw materials and or lenses been received, ordered, etc.?
So the latest logistical data, we've gotten the inserts in already. We have probably enough raw material to manufacture 50 lenses. And we'll probably have to manufacture another 60 lenses to do all the testing that we need to do. That order is already in with our material provider, and the delivery date on that is the first week in January. The only other thing that we have to do is there is the larger mold. I showed you the single mode in my presentation, but there's a larger mode where we can make, 6 to 8 lenses at a time. That has not come in. That's coming from China.
This one's a little beyond me. Will there be a toric version of the lens?
Yep. Yeah. So toric lenses correct astigmatism, and that's just a fancy name for the lens itself. So we've already talked about it. We've already looked into it. I can't tell you where it's positioned in the strategic document, but it is something that we are considering to continue to round out the product portfolio. We don't want to be just a one product company. We want to be able to round out the portfolio. And that would be a good lens to add to the portfolio at some point in time in the future.
All right, well, I think we're running out of time. There's one last question that I'll throw down, and then as for those that didn't have their questions answered, you can email either Dean or myself. Again, our emails are dayton.marks@ocumetics.com for me, and for Dean, it is dean.burns@ocumetics.com. The last question that we have here is how is peripheral vision, or is there anything you can comment on with respect to peripheral vision?
Yeah. So there are two components to peripheral vision. One is whether or not you normally have good peripheral vision before surgery. And so there are a number of tests when they bring you in to see if you're a candidate. They will test that, and they have machines, devices that can actually test that. You can actually test it yourself. Just put your fingers close to uh, out in front of you and try to pull it back as far as you can. And if you can still see things out here, you've got pretty good peripheral vision. So they'll test that to make sure that you already have good peripheral vision. The challenge that we have to manage with IOLs is what we call edge glare. So that's a distraction of light coming in from the side that can create a problem. The way we mitigate that with the Ocumetics lens is the what we call the retainer, which is the thing that actually holds the optic in place, and it's got its own haptics that hold the lens in place. Uh, we do that right now with our retainer. We may have to colorize the retainer more so that we don't get edge glare. And we'll cross that bridge when we get to it. Right now, we don't think that we will get edge glare, but if we do, we'll just put a color dye into the manufacturing of the lens just to make sure that we can reduce that.
Excellent. All right. Again, just for those that didn't have their questions answered, I think we're out of time, unfortunately. But like I said, you can send the emails to both Dean and I. For Dean, it is dean.burns@ocumetics.com. And for myself, dayton.marks@ocumetics.com. You can email either of us, but Dean's usually on top of his emails pretty quick. I think that's really all I have to say. I'll leave it over to Dean to end the webinar.
I first want to thank everybody for spending the time with us on the webinar. I noticed the count was really strong and it's still pretty strong. So I thank all of you for spending time with us. My goal is to be as transparent as I can and to drive this technology into the marketplace. With medical, science, pharmaceuticals, you're going to have your ebb and flow. So everything's not going to be just a smooth journey. What I want to do is I want to smoothen out the journey and let you know where we are and let you know what decisions we're making and why we're making those decisions. So I'm just going to ask you guys to continue to stick with us. This was a pledge that I made when I took this job, and that is I'm going to communicate. I love to over communicate anyway, but I'm going to communicate with you guys to make sure that you know exactly what's going on and how we're doing it. This is not the first time I've done this, and I can tell you it probably won't be the last, even though there are days I say this is the last time I'm going to do this. But I just love the industry and the market, and I love this particular. I came out of retirement to actually do this particular project. So if nothing else, that should speak volumes of where my commitment is and what I'm trying to do. So with that in mind, if you have concerns, questions, if you need to understand where we're going, feel free to just, send me a message. You can even call me. I'm pretty good about answering the phone, and I'll let you know exactly where we are. I may have to manage the communication because as a unapproved product for the FDA and because we were a forward-thinking company with TSX, there's certain things I can't say or certain questions I can't answer or certain directions I can't give you because it's illegal, but I will try to give you the best information that I can at the time you ask that question. So with that, I salute you, I thank you, and hopefully we'll get a chance to do this again on the other side of the holidays. So if I don't talk to anybody between now and the new year, have a great holiday. Have a great New Year's. Be safe out there. And I look forward to talking to you when we get back on the other side. Take care. Bye bye.